Well, thanks, Henry, and thanks to the organizers for getting this meeting together. It's really exciting for me to come here and listen to all the great science being presented. So my task during the next 35 minutes is to give you first a crash course in a few minutes about osteoarthritis, what it is, and secondly, to pick a few possible targets for novel therapies out of the multiple targets that might be considered in today's research. And in addition, of course, we're hearing much more about that during all the presentations to come during this meeting. So what do we know about osteoarthritis? Well, it's by far the most common joint disease. It accounts for more functional limitation and disability than any other chronic disease among the elderly. It's the most common indication for replacement of the joint. The costs are very significant, about 2% of the gross national product. Patients often have comorbid medical conditions, and osteoarthritis is also actually associated with significant excess mortality, in particular with or from cardiovascular disease. And the reason perhaps why I'm standing here today, we have no disease-modifying therapy. We can help the patients with their symptoms, but we can't stop the disease. We can't reverse the disease. We can only, I say only within double quotation marks, replace the joints when the disease gets too severe. And that's been my clinical business. Now, the roadmap for this presentation is I'll spend a few minutes telling you about what OA is, why do we get it, how do we treat it, and then the meat of the presentation on pathogenic mechanisms and possible novel treatment targets. So what is osteoarthritis? Well, that is in the eye of the beholder to some extent at least. We might regard, or at least if we're working in the laboratory and looking at cartilage samples from patients, and this is a sagittal section of a human knee joint, and this is the tibial cartilage, and you can see some early stage changes from the surface of this cartilage that we might describe as perhaps being pre-OA. But I would dare say this patient probably does not have any symptoms. Later on, perhaps in the same knee, a few years later, that cartilage will be further damaged. There'll be other changes in that joint cartilage, and quite likely at this stage the patient will have symptoms. We will also be able to, if we're using radiographic techniques, plain X-rays or MRI, be able to see changes in the structure of the joint, loss of joint cartilage in the medial compartment of the knee joint here, or on the MRI image, also loss of joint cartilage, which is the black stuff here in between the bony surfaces of the knee joints. So this would a radiologist clearly diagnose as osteoarthritis. And we could also define the disease by asking the patient, are you over 50? Have you had knee pain in your knee for most of the days of a month during the past year? And various other questions which you use in the clinical situation. Now, all of these definitions, different definitions, criteria, phenotypes, if you will, of osteoarthritis are correct. It just depends on what the circumstance is in which you're using them. So if you're an epidemiologist, you might use these questions to define osteoarthritis. If you're a radiologist, you would look at X-ray images. If you are a geneticist, you might be using some genetic variations, etc. And all of these definitions vary. So we need to be clear when we're talking about osteoarthritis, what particular definition, what is the setting in which we're studying disease. Now, I often use this diagram to describe osteoarthritis, where we have a vertical scale with a normal situation, a normal joint up here, and worsening disease as we go down, and a time axis going along the horizontal here from the early insult to the end stage, and where the earliest change or the earliest insult might be truly an insult, such as a joint injury, but it might also be something which we really often cannot define, which initiates a disease process and which then continues through a symptomatic and radiographic stage to an end stage, which may or may not be a joint replacement for that patient when the disease gets so severe that it cannot be managed by other means. However, the majority of patients with osteoarthritis actually spend their lifetime here in the middle, and a minority actually progress to needing a joint replacement. Now, the criteria, the definitions for osteoarthritis that I just described to you, they do not completely overlap. There is only a partial overlap between what the patient experiences and what we can see on the X-ray changes, or what we can see if we take a cartilage samples out of the patient, or if we take a biomarker sample from the body fluid, etc. These changes partly overlap with these. And we may, of course, discuss which of these is the most important one, but if you talk to the Federal Drug Agency in the US, for example, or the European regulatory agencies, this is, of course, what counts from the view of the regulatory agencies. But from a pathogenic disease mechanism point of view, these kinds of changes, of course, are quite important still. I'll come back to this particular issue later. So who gets osteoarthritis and why? Well, age is a very important factor in getting your OA. Your family, your parents, another critical factor. And finally, of course, lifestyle, environment, in other terms. So aging, the effect is shown here in the age-related prevalence of this disease in men and in women in various regions of the world, data from the World Health Organization. As you can see, there is a monotonous increase after the age of approximately 50, rising sharply. What about the genetic environment, the genetic influence? Yes, of course, like any other disease, there is quite a significant genetic component, and where the particular influence of that genetic component varies between different individuals and with different phenotypes. So that in some individuals, there is a dominant genetic influence, while in other individuals, it is more difficult actually to define the genetic influence. Lifestyle, finally. These factors are as important, or perhaps more important, at least in the short term, than the other factors, because these are modifiable factors. We can do something about them today, actually. And there are two major factors. One of them is obesity, because obesity, physical inactivity, and weak muscles are associated with a very high risk of osteoarthritis. Let me give you a couple of data for a change. We did a study in a city in Sweden in the mid-90s of about 28,000 individuals, then followed these individuals up 11 years later and linked the baseline data to the joint replacement registries for our country, which are essentially complete since more than 30 years back, to see what the association between BMI and joint replacement was. And the data we generated looked like this. These are so-called survival curves of the proportion of knees not having a knee replacement. And this is the time axis. So here we have about 5% of the patients having a knee replacement within 14 years. And these are the quartiles of BMI at baseline. And the top quartile here, about 7,000 individuals. Each symbol represents one joint replacement. And you can see the difference between these curves quite graphically and quite easily. There are very few, actually. You can count them almost on your hands and toes over 15 years among these 7,000 individuals with what I would say an ideal BMI. Compare that to the density of joint replacements occurring in the heaviest quartile, which has a BMI of roughly 30, and you will quite easily see the influence of BMI on the risk of a joint replacement in these individuals. Is this important? Yes, it is. Look at the data from the United States in 1990 for the proportion of persons with a BMI of 30 or over, 2000, and 2010. We have an epidemic of obesity in the United States, and we can use the US data because they are the best so far. However, the rest of the world is following on, as in many other aspects. And in many other countries, including those in Asia, obesity is becoming a significant problem, and that has an impact on the need for, among other things, joint replacements. And if we look 20 years forward in time, we can today actually project the increase in the need of joint replacements because of osteoarthritis in the US. And that's because of things that already have happened today, because these are the individuals that will, the obese individuals living today, that will be needing a joint replacement 6 times more than today. So these all have very significant issues. Knee injury leads to osteoarthritis. We know that. That's another lifestyle factor. And we know that in the population, we have this expected proportion, this expected prevalence of knee osteoarthritis. And if you have a meniscus injury, for example, at the age 35, and follow these individuals up 17 years later, that's what you find. And thus, these individuals have this trajectory for developing osteoarthritis as compared to the population. Similarly, if you have an injury of the anterior cruciate ligament in your knee, you will have another trajectory here showing that you have in the population following a joint injury, young people with old knees. So how do we manage this osteoarthritis among the young and the old in the population? Well, just one slide to summarize. We have a treatment, a basic treatment, which is information, exercise, weight loss, and self-management. For those where this is not sufficient, we provide drugs and walking aids. And for the minority where these interventions are not sufficient, who progress, we use surgical management. However, I might add that all except joint replacement have small to modest effect sizes. In other words, are not very effective. Many of the drugs we use have significant adverse events associated with them. And the fact is that exercise and weight loss is as effective as drugs. So to conclude from this brief summary, there is a clear and unmet need for effective and safe treatments for osteoarthritis. There is no disease-modifying treatment today. There is no treatment that stops the disease development or reverses it, actually. That's why we're here, at least in part, today. So with this background, let me then use some of the risk factors, some of the reasons I pointed out for why we get osteoarthritis, to again go through the potential novel treatments that may be associated with some of these risk factors which I just explained to you, such as age, heritability, and lifestyle. What about aging? Why does that lead, why is that associated with osteoarthritis? Well, we know from data published quite a while ago that cartilage, the tissue on the surface of the joints, actually deteriorates in its ability to carry load and respond to load with age. So the tensile fracture stress of human femoral cartilage decreases quite dramatically with age. In essence, saying that the cartilage becomes more brittle. Why is that? Well, we don't know really. We don't understand that. One of the potential factors might be the accumulation of glycation end products. That's one possible explanation, but quite likely not the only one. Looking at the cells, the chondrocytes, and the other and the cells in the other joint tissues, we know that senescent cells accumulate in tissues with aging. We know that senescent cells also express surface-bound IL-1 alpha, which in turn activates signaling cascades, including NF-kappa B, and so on and so forth, leading to the expression of IL-1 alpha, IL-6, IL-8, MMPs, and so forth, in an increasing at an increasing rate in senescent cells. There is also quite an interesting report from last year from Baker and co-workers who showed that lifelong removal in knockout mice of the senescent cells delayed the phenotype onset in the progeroid mouse model. And late life clearance of these cells also attenuated progression of established age-related disorders. This may indicate potentially that cellular senescence in joints, as one example, it may be causally implicated in generating the age-related phenotypes that we can observe, and that possibly if you could remove these cells, that would be a way of intervening in the aging process of the joints. Now, what about genetics? Our big hopes. It has been and remains so, but progress has been quite slow in this particular area. Classical twin studies show that 50 or 60% of the heritability for knee and hip OA explain osteoarthritis in the knee and hip. However, all the genetic variants identified so far represent only a very small proportion of that known heritability, maybe 1 or 2%, and the rest is really a heritability gap. We really don't know where or how that heritability is represented. That is a major area of research for the future. Now, a great number of potential genetic variants have been identified so far, but I would dare say that perhaps it is only the top line on this slide, the growth factors and the regulators, GDF5, Frisbee, etc., that have been replicated sufficiently well in different populations and in sufficiently large studies so that we can have some trust in these findings. There are a number of other potential interesting targets, but I would say they still await sufficient replication. Now, what about these growth factors? What about these regulators? Well, there are some interesting findings relating to that and further to osteoarthritis, in the sense that Frisbee variants are associated with shape variations in the proximal femur. And we know that these shape variations actually influence the risk of getting osteoarthritis. And we know from a study published earlier this year that Frisbee variants, a particular Frisbee SNP, may be altering relationship between hip shape and osteoarthritis. So that provides a link between the early development of these joints and the risk of getting osteoarthritis in adult life. Just a couple of examples from the slide shown here. And this would be a normal hip with the proximal end of the femur and the acetabulum. And classically, of course, we've known for a long time that acetabular dysplasia, a shallow acetabula, increases the risk for getting osteoarthritis. There are other variants, such as this so-called pistol grip deformity, which are also associated with an increased risk of osteoarthritis. And there are additional recent findings from the knee joint, which also suggest that, again, the shape of the joint may actually be quite important. So what about lifestyles? What about overweight and obesity? Again, coming back to that. Why is that a risk factor for osteoarthritis? Well, there are two possible pathways which are affected. One is the obvious one, the overload of your joint. If you're normally active, you take about 10,000 steps each day. That makes millions of steps each year. That makes 100 million steps or something like that in a lifetime. And if a large proportion of that is spent being obese, that means that you will be overloading your knee joint at every little step you take during your lifetime. And that is too much for the joint, so to speak. There is also the other potential pathway being activated by way of metabolic stress, and where obesity is associated with the chronic inflammation, and where adipokines and so forth from the adipocytes and macrophages in the adipose tissue may represent a link to osteoarthritis. And I'll come back to that in a moment. What about the overloading and osteoarthritis? Well, clearly joint cartilage and joints are designed to be loaded, and they need to be loaded to function normally. If you don't load your joint, that's not good. But if you overload it, that's also not good. So chondrocytes, clearly, like bone cells, are receptive to mechanical stimulation. But overload activates NF-kappa B pathways, activates stress-induced pathways, etc., leading in the end to activation or expression of MMPs, ADAMTS, etc., and cartilage matrix destruction. So that may be one obvious way in which obesity is linked to osteoarthritis. And the other pathway is somewhat less clear, but there are some very interesting animal model data suggesting that the high-fat diet induced by osteoarthritis in mice induces osteoarthritis in mice, apologies, and that this is inhibited by statins and PPAR gamma agonists like rosiglitazone, for example. The inhibition of osteoarthritis by these two agents was actually also observed, interestingly enough, in other osteoarthritis models, not only the one induced by high-fat diet. However, the mediators that are active in the metabolic stress situation and which interact with the cartilage are less clear at this time. But obviously, with the common use of these agents in the population, this is an area that is very actively being explored at this time. So what about other lifestyles? What about acute injuries? What about joint injuries that I pointed out as being one other risk factor in the environment that interacts with your genetic background? Well, an acute joint injury activates just about everything in the joint, as you might expect, as any other tissue injury would. But in the joint, we know that there is release of free oxidant radicals, there is chondrocyte apoptosis, telomere shortening, inflammation activation, and activation of pathways related to Wnt and Frisbee, leading to matrix degradation, growth factor release, bone turnover, etc. A real cascade of events initiated by the acute injurious event. Just to give you a couple of examples that we can, in the human, in vivo, monitor these events by looking at joint fluid aspirated from the injured joints, and we can measure, for example, IL-6 in relation to time after injury. We can measure downstream products like MMP3 in synovial fluids from these injured individuals. We can measure further downstream products such as the aggrecan fragments generated by ADAMTS4 or 5 degradation, which again is something that's activated by this joint injury. We can also, interestingly enough, find high concentrations of tenascin C in joint fluid. And tenascin C, as you know probably better than I do, is quite common. We have a lot of it in the joint during the early development of the joint, but it essentially disappears in the adult joint, but is re-expressed in the injured joint in a very significant manner, as shown here in these samples shortly after joint injury in comparison with the reference levels here, which are the normal ones. Now, tenascin C is interesting in comparison to some of the other biomarkers that I showed you, because we do have TLR4 present on the surface of chondrocytes, and we know that tenascin C is an activator, is an endogenous activator of TLR4, and one proof of that is that mice lacking TLR4 are protected from erosive osteoarthritis. We also know that tenascin C fragments induce expression of ADAMTS4 and a dose-dependent release of aggrecan fragments in cartilage. So tenascin C may be an example where the presence of these fragments actually denote joint injury, but the presence may also drive further joint injury and generate or create a vicious circle to prolong the degradative injurious phase. And this segues into the next potential mechanism being activated by joint injuries, the release of alarmins into or from the cells, and which again may activate TLR4 receptors in chondrocytes and in the synovial tissue, and where the stimulation of human chondrocytes with alarmins causes an upregulation of catabolic markers mediated through the TLR4, just like the tenascin C fragments that I just showed you. This is work that was just recently published in Arthritis and Rheumatism by the group with Wim van den Berg, etc., in the Netherlands. A further disease mechanism or mechanism activating injurious mechanisms in the cell or in the joint in connection with injury and osteoarthritis was published last year in Nature, where Wang and collaborators showed that the expression and activation of complement, especially the membrane activating arm, is highly upregulated in the osteoarthritic synovial membrane, and that the complement co-localizes with MMP13 and ERK expression, suggesting that this may be one further mechanism by which destruction of the joint tissue is activated, both in joint injury and in the later chronic phase of osteoarthritis development. So clearly, joint injury is common, and it activates multiple pathways in the joint, which lead to chondrocyte and matrix overload, which leads to activation of stress-induced pathways and matrix degradation. What I summarized in the last few slides were the events taking place in the acute phase close to the injurious event. However, many of these mechanisms also appear to be active during the development and in the in the overt phase of osteoarthritis, later along this pathway, along this time-related pathway of osteoarthritis development. So many of these pathways and activations which I've exemplified using the acute joint injury may also be relevant for the active phase, the chronic phase of osteoarthritis development later in life of these patients. What are the consequences for the function of the joint? Well, I'll show you some data published a few years back showing that removal of the meniscus alters the dynamic deformation of tibial joint cartilage. So we're looking at the knee joint from the side here. This is the femoral surface, this is the tibial surface. And using a sophisticated imaging protocol, these investigators showed that if you remove the meniscus from the knee joint, the normal deformation pattern under load of the knee joint cartilage changes quite dramatically, and some areas of the joint deform much more dramatically and others deform far less than they do in the normal physiological situation with the intact anatomy. This has consequences, again, over a lifetime of taking 10,000 steps every day. And we can look at the same phenomenon here in a study published by Van de Velde and Guan Li in a few years back, where again they used a sophisticated imaging protocol, combining plane radiographs in two dimensions, two different orthogonal directions with MRI images, and showed that in the knee which had a ruptured anterior cruciate ligament, the knee with the ruptured ligament deformed, the cartilage in the knee with the ruptured ligament deformed much more under this normal physiological movement than the normal cartilage does. So again, this shows that these types of injuries and these processes which are just exemplified lead to very clear and right functional changes in the joint cartilage. And these changes lead to the destruction of the joint over time. Now, let me come back in the last few slides here to what I started out talking about, that what we're looking at, what the patient comes to me for, is not because the patient has an X-ray that does not look normal, or that the patient has a bump perhaps on the knee joint somewhere. The patient comes to me because the patient has symptoms. The patient has pain in the knee joint. That's why you usually go to the doctor. Now, why do we have pain? Well, that's interesting in itself because joint cartilage does not have any nerve endings in it. But so clearly the pain comes from other joint tissues, perhaps the subchondral bone, the joint capsule, the synovium, etc. And these pain stimuli are transmitted clearly to the central nervous system and where you experience the pain. Now, with chronic pain, we also have phenomena such as multi-level sensitization of pathways, both at the in the peripheral compartment, in the spinal compartment, and in the cortical compartment. And these processes in itself are worthy of a presentation in itself, and it's far beyond my own expertise, but it's clearly a very important area if we are to understand the symptoms of our patients. But let me take a couple of other examples which I think help explain why some patients with very mild changes actually in their joints have quite significant pain and symptoms, while other patients with very dramatic changes on the X-ray films have little or no symptoms. This has been quite a dilemma for us in trying to understand over the time, but perhaps some of the more recent data now help us understand this. So for example, here we have the TRP1 pain receptor, which, by the way, is the wasabi sensitive receptor, where a particular genotype is involved in lower peripheral pain sensitivity, and where this particular genotype is associated with a decreased risk of having painful knee osteoarthritis in the human population. Data published last year by the group in London. Interestingly enough, also, this particular genetic variant is associated again with having less symptoms in your knee with radiographic changes than in the rest of the population. So these are findings which help us explain why some patients have more symptoms with the same type of structural changes and others have less. And finally, there is a role for PACE4 in OA pain. Data coming out in our Annals of Rheumatic Diseases in one of the most recent issues, where a SNP associated in the PACE4 gene was associated with OA symptoms in patients with radiographic osteoarthritis. Again, similar types of studies as in the previous slide I showed, again, helping to explain, in part at least, why some patients have more symptoms and others have less symptoms, indicating that, of course, your genetic background also influences your pain sensitivity. Not surprising, but at least now we're having some really more specific pathways to explore. Now, I've given you some fairly subjective examples of novel targets and novel pathways which are being explored today, which may present with opportunities for better treatments of osteoarthritis in the future. That clearly has been a very subjective selection of a large number of potential targets. So trying to summarize, we do have in the osteoarthritic joint synovial inflammation with release and activation of the agents indicated in the slide here. We do have cartilage and meniscus damage where potentially inhibition of some of these agents may present opportunities for disease modification, for influencing disease progression. We do have, as I mentioned, the metabolic stress pathways being activated, and we do have finally something which I've not really gone into today, the accelerated bone turnover. And there is clear evidence of a crosstalk between bone and cartilage in these joints with osteoarthritis, not only in the acute injury phase, but also during the chronic disease phase. And these pathways represent opportunities that I think are worthy of further investigation in trying to really do something about a disease which is really quite a challenge for us to deal with. And if you are interested in hearing more about this, I suggest you sign up for the Congress on Osteoarthritis and Cartilage in Philadelphia in April next year, organized by ORSI. Thank you very much for your attention.
That was a beautiful overview over a very complex disease. So my question is, to what extent do you think that some of the biomarkers, tenascin C, for example, and other cytokines that are upregulated following an injury to the joint, to what extent do you think they are part of a normal repair response within certain limits? And at what stage do these repair responses become contributing to the progression of OA? That's one question. The second question is, you mentioned pain and neuropeptides. And to what extent do you think that neuropeptides associated with pain fibers and activity of pain fibers might contribute to the progression of the disease as well?
Well, to start with, Björn asks me about the release of some of these components that I just exemplified here, to what extent they represent a normal or are involved in a normal, quote-unquote, repair response to an injury. That is a question which we are trying to, or a challenge which we're trying to look at. And clearly, that is the case. Some of these agents which are, or pathways which are upregulated, are clearly part of a tissue repair response, or a wound healing, if you will. And the challenge, of course, is if we're looking at, say, the acutely injured joint and say, what if we try to inhibit some of these pathways to prevent development of osteoarthritis later downstream? That in itself is a challenge in designing the appropriate study, of course, but let's forget about that for the moment. But what consequences would that have, that inhibition in that early phase of the repair response, quote unquote? And the answer is, we don't know. But it's clearly a question that is present in when we're trying to design studies which are currently being done. There are some pilot studies using, for example, IL-1 inhibitors in the acute injury phase, and trying to understand exactly what the consequences are in the human joint, in the acutely injured human joint. Now, your second question with regards to pain, neuropeptides, etc. Well, quite a ways beyond my own expertise, but I do realize that there is crosstalk between, let's say, neuropeptides, inflammation, and some of the other activation of some of the other pathways that I mentioned here. Again, that is something which is not very well understood in these situations. We know that from other models that, yes, there is crosstalk, and certainly that neuropeptides may induce inflammation and vice versa. But I think the examples I gave at the end, where we're at least beginning to understand a little bit about the variation in pain sensitivity between different patients with osteoarthritis, helps us deal with some of the questions that we've been scratching our heads about over the last 20 or 30 years. So that's about as far as I dare go in trying to respond to your question.
Yeah, this is a great overview. I have two questions. One is you mentioned so many, several prevalent factors which could cause OA, but do you know or do you have any insight about the targeting cell? Is a synovial cell? Is
you were saying the targeting cells?
The initiation of the OA, of this, caused by this factor, primarily targeting articular chondrocyte, meniscus, or subchondral bone, where OA is initiated. That's my first question. The second question, you mentioned the cell senescence, but when we do the axial staining, there's 90% of the cell in the bone marrow cell is become positive. There are only a few articular chondrocyte become positive, suggesting the articular chondrocyte cell senescence is in very low percentage. My question is really articular chondrocyte cell senescence or the bone marrow cell subchondral, beneath the subchondral bone cell senescence?
Well, thank you. That's an important question, an important added area which you're pointing out. My presentation today, by being forced to explain osteoarthritis in 35 minutes, was clearly chondrocentric in the sense that I choose to focus on one particular tissue in the joint. But osteoarthritis is not a cartilage disease. It is a joint disease, and the joint contains bone, bone marrow, synovial tissue, a multitude of cell types, etc. And there is clearly crosstalk and interplay between all these cells in the joint in this disease process. And there is work from several groups, among them Alan Grzinski's group at MIT in Boston, showing clearly the importance of the talk between chondrocytes and, for example, synovial cells in the joint capsule in initiating and potentiating the processes, the pathways, the cascades being activated, for example, by overload and joint injury. And as you point out, quite clearly, bone reacts very early in osteoarthritis, and there is an ongoing discussion in the osteoarthritis research community on whether actually the first events take place in bone or whether the first events take place in the cartilage. And I think the jury is still out. We don't really know, but we know that both tissues react very early when we look at our various models, including bone marrow and subchondral bone.
The cell senescence? Do you have any comment on the cell senescence?
No, I don't. This is not my area, but I think it's a very interesting and intriguing topic that should be pursued with regards to this particular disease also.
So in the interest of time, please make sure the questions are short and so that the speakers can address in a short time as well. We'll have a couple more questions.
I only have one question. As we all understand, the articular cartilage and subchondral bone is one function unit. You already addressed the bone response to the mechanical loading environment. During aging, ligament injury, or obesity. So the loading on the joint is not that stable. So the subchondral bone will respond. So the response could be very early event of OA. My question is, will that be a good target? And can you make a comment? And what the initial event, whether that's the key event for OA development?
Well, I think one of the key events in a large proportion of the cases of the patients with OA, and the cases with OA that we're looking at, is actually a change in biomechanics. Biomechanics is not the only, but perhaps the dominant force in driving OA. Now, that change in biomechanics can come about through a variety of different reasons, such as differences inborn or differences in joint shape that were driven by genetic variants in growth factors and regulators during your growth, embryonic and early years of growth. It may also be affected by joint injury, etc., etc. But biomechanics is a very dominant driving force in osteoarthritis.
Thank you.
I have a brief question. It's a very interesting microenvironment where one sees the onset and progression of osteoarthritis because intense inflammation, high levels of cytokines, yet one finds very, very minimal transformation, very little cancer in that region. That's an environment that would characteristically be linked to being conducive to transformation. So my question is there anything about the fact that you have an increase in senescent cells that may be providing bioprotection?
Well, clearly, I didn't catch all of your question, but let me try and answer anyway.
You can get partial credit.
Clearly, senescent cells, senescence is a result of aging, but also senescence can be accelerated by, for example, a joint injury. And I think the end result will be the same.
It's just a nice environment where you're going ahead and you've got inflammation and you don't have transformation. Normally you find increased tumorigenesis in the presence of transformation. So senescence of the cells might be going ahead and giving you the required protection.
I'll answer yes. That's as far as I'll go.
Is gentle exercise protective for osteoarthritis? If you normalize and get rid of any of the effects on BMI, is the simple act of movement itself,
The simple act of
movement, going to be protective?
I couldn't hear the last part. I'm sorry. I'm partially hearing
Is
impaired.
joint flexion, is gentle exercise, is bicycling or swimming?
Can we still exercise gently without being very aggressive with our joints?
Yes. Again, as I mentioned, there's an optimal window of loading for your joint. Too little is not good. Too much is not good. How much is too much? And you really have to go to the quite extreme end of that clock bell-shaped curve. There are some recent data published actually from a Swedish study where they looked at the skiers who participated in the Vasa ski race, which is an annual race that has been running in Sweden for about more than 50 years. It's a 90-kilometer cross-country ski race, which the good ones do in 2-something hours. Really quite extreme. They have very good records for a long time back of who finished at what time. And in order to register for that race, like marathons today, you have to tell the organization how much training you've had, how many hours and whatever you've done in the past year. So they have that data too, and we linked that data to the Swedish National Joint Replacement Registry for Osteoarthritis and looked at the relationship. And there is a clear relationship in that extreme end between how many hours, what finishing time you had, etc. So the more you do, and as an extreme athlete, the higher risk you have for getting osteoarthritis. But it's important to emphasize that this is way out on the toe of that bell-shaped curve. and regular exercise is good for you, period. As long as you don't injure.
There you go, excuse for not exercising, Andrew. Well, with that, to move on to the rest of the program, and obviously thank you very much for a very stimulating talk. So we're going to continue the theme of human skeletal diseases, as beautifully illustrated here using OA as the paradigm. That they are both genetic and non-genetic, or loosely speaking, epigenetic factors that influence all kinds of skeletal diseases. And I actually do have a slide well, in the interest of time, forget about my slide. And so so in this session then, we're gonna follow that theme and to illuminate some of the molecular basis for both genetic and epigenetic factors in determining human diseases. And the first speaker we have is Brandon Lee, who is going to be studying osteogenesis imperfecta, and he's going to tell us some more recent progress in defining the molecular basis for this very common human disease. And then he's also going to tell us what we can learn by studying these kind of diseases, how the matrix interacts with the cell.
Thanks, Manchin, and thank you, the organizers, for inviting me to talk to you a little bit about our work in osteogenesis imperfecta. As he mentioned, unlike the complexity that was so beautifully represented early on in this previous talk, we have focused on Mendelian disorders. And the advantage of Mendelian disorders, although they're often quite rare, is that there's a strong biological effect. And as we understand the allelic spectrum of genetic disorders, I think you'll see that we can actually gain tremendous insight in terms of novel biological mechanisms. I'm going to talk to you about osteogenesis imperfecta. This is one of the earliest osteodysplasias that have been characterized in the human genetic world. The mutation, as many of you know, has involved type 1 collagen, which is the most common protein component of bone, as well as some of other connective tissues. And the state of the art for almost 30 years has, by many of the pioneers who identified the first mutations and mechanisms in OI from the late 70s to the early 80s, has been structural mutations that affect this molecule, this trimeric type 1 collagen molecule, which undergoes an enormous amount of post-translational modification. And I don't have time to go through all of that, but suffice it to say, the clinical phenotype of dominantly inherited OI can be quite variable. It can be type 1 OI on one end of the spectrum, where you can have, in fact, almost normal bone mass, but just sporadic fractures. Or it can be more severe. This is sort of on the range of OI type 3 and type 4. You can see the curvature of the bones, the shortening of the bones, and the recurrent fractures as shown here in the femur. And again, a quite diverse spectrum from mild end to a very severe end. Several years ago, the field changed when we identified a novel trimeric complex that the founding member of which was CRTAP or CRTAP. And this trimeric complex involved another protein, P3H1 or leprecan or lepre1, as well as cyclophilin B. And what was important about this trimeric complex was that this was essential and required for a post-translational modification of collagen that actually had been very poorly understood. And this is what we thought at that point was a unique hydroxylation of a proline at position 986 of the alpha-1,1 chain of type 1 collagen. As many of you know, 4-hydroxylation of proline is a common event and is required for the thermal stability of the trimeric structure, but this 3-hydroxylation event was really poorly understood. And Roy Morello, who was a postdoc at that point, had knocked out CRTAP and showed that the mice had low bone mass. There was altered collagen fiber diameter. There was a tremendous decrease in osteoid in the bones of the mice, and the collagen was slightly over-modified in terms of post-translational modification. And importantly, in patients with mutations of CRTAP, you could have, again, a clinical spectrum where no mutations led to a recessive form of severe OI, in this case, clinically OI type 2, while a hypomorphic form led to a type that Francisco Laurier had characterized, OI type 7. But radiographically and clinically, a severe form of osteogenesis imperfecta. And the prediction was that other components of this complex would similarly lead to loss of the complex function and loss of this hydroxylation event in OI. And in fact, that's been the case. We and others have since shown with an explosion of multiple other genes in this family that mutations in P3H1 can lead to, again, a severe form of OI. Mutations in cyclophilin B encoded by PPIB, again, can cause this form of osteogenesis imperfecta. Now, what's important to keep in mind is that this post-translational modification event targets many fibrillar collagens as well as non-fibrillar collagens. And so the prediction would be that loss of function mutations would not just cause a bone phenotype, but really lead to a true generalized connective tissue disease. And in fact, patients as well as mice mutant, for in this case with CRTAP, have a true osteochondrodysplasia. So they have a cartilage phenotype. So shown here in the disorganized growth plate versus control. You can see the low bone mass even in this histological specimen. And importantly, as you would expect, because collagens and fibrillar collagens are in multiple connective tissues, you also see a phenotype, albeit more subtle, in the animal model. So for instance, in the knockout mice shown on the top panels, you can see this sort of pulmonary phenotype, which is really a developmental phenotype in terms of the alveolization and the branching that occurs in the alveoli of the lung. You see the increased spacing, much like you would see in an emphysematous lung in an adult. If you look at the kidney specimens from these mice, you see a glomerulosclerotic phenotype shown here in the H&E as a picoserous red. And on ultrastructure, in the knockout, you can see the collagen deposition that you often see accompanying this type of histological phenotype. What is also important to keep in mind is that there's a parallel cellular phenotype in these connective tissues. And so, for instance, in lungs as well as in kidneys, you see an increase in cell proliferation. And this already then begins to hint at the consequence of mutation either in the complex or in the loss of this hydroxylation event in collagen to leading a disturbed cell matrix interaction, which is really the theme, I think, of thinking at altered matrix in terms of the connective tissue world. Now, a little bit about the mechanics of this complex. When you have mutation, either in CRTAP or in LEPR1, you lead to a destabilization of the complex. So this is an immunostaining of patient cells with the CRTAP antibody on the left, a P3H1 antibody, two of the important components of the trimeric complex. And what you see is that in patients who have a mutation in CRTAP or a mutation in P3H1 encoded by LEPR1, you lose the whole complex, irrespective of whether you stain with CRTAP or with P3H1. And so this leads to a complexity in trying to understand what's the consequence of the pathogenetic mechanism. Because what we have here is a sort of an ultrastructural and histological phenotype. So we know that when you have mutations in this complex, you have post-translational modification, much like as you would see in structural mutations of type 1 collagen. We know that there's altered secretion. And because of this, we know that this complex has also a chaperoning effect in the ER of cells. There is clearly an altered ultrastructure of collagen. The collagen fibers are thicker. We see decreased osteoid deposition histologically. So even though there's a faster secretion of collagen fibers, it's not stable and deposited in osteoid. Having said that, what is deposited is mineralized in a faster fashion. And so much like many of the OI studies, whether it's structural mutations in type 1 collagen or this class of OI, you actually get increased or accelerated mineralization. And there is a generalized connective tissue phenotype affecting bone, cartilage, skin, kidney, and lungs. So the question then is, well, what is the underlying pathophysiologic mechanism when you have mutations in this complex? Unfolded protein response has been shown to be present in different studies of cells from OI patients, and one could imagine this correlates with the post-translational modification. Clearly, there's altered collagen fiber assembly. So really, OI has been a model of effects both in the cell and outside of the cell. We affect fibril assembly. I've pointed to this issue of perhaps altered matrix cell signaling, and could it be a chaperone function of the complex itself? And so really, a diverse spectrum. And in all likelihood, all of these probably contribute to some component to the OI phenotype. And I think the underlying hypothesis is that they each may contribute differentially depending upon the tissue that you're looking at. Now, how do we begin to start to sort this out? Well, David Ayer, who's part of the program project that we have studying this problem, has shown, in fact, that there are other sites in type 1 collagen, in this case, which is also 3-hydroxylated. These are what we call non-canonical sites. So they're not dependent on the trimeric complex. And this is an extremely evolutionary conserved post-organizational modification. This type of organization actually supports actual function of the 3-hydroxylation site as a register for fiber assembly because of the staggered array that occurs in collagen fibers. So one popular hypothesis is that the hydroxylation itself helps to organize collagen fiber assembly, and that when you lose this, you lose the register, and this leads to unstable collagen fibers. If this were in fact the case, one would predict that unhydroxylated collagen should have a dominant negative effect on normal collagen fiber assembly. And so Ingo Graf and Dustin Baldrud went about testing this in a very simple approach. They hypothesized that if you lose hydroxylation at this proline, and in this case what they did was generate 2 simple transgenic mouse models, one with an alanine substitution, because alanines are very, very common at the X position of GlyXY, and was predicted not to alter the triple helical assembly, and one with the normal proline. If you were to generate this transgenic mouse, if the unhydroxylated collagen itself would have a dominant negative effect, we should see an effect in bone. And in fact, that's exactly what they see. This is 2 transgenic, there are actually multiple lines that were generated, but 2 representative ones with similar levels of expression when you look at the P3986 ALA mutation versus a wild-type collagen, both showing about a 50% increase above the wild-type collagens in the bones of these mice. And what you notice is that basically you see a low bone mass phenotype here only in the mice that expressed the alanine substitution, not in the wild-type mice. I don't have time to show you a lot of the other data, but basically David here has shown that in fact you have about one-third proportion of unhydroxylated collagen in this situation. So these data suggest that in fact when you lose that hydroxylation collagen, you actually can have a dominant negative effect on fiber assembly, and in this case lead to the low bone mass phenotype. This, however, doesn't get at the other essential question: is there a function or the chaperone component unique to P3H1 that is not, or that's not uncovered because of the fact that when you lose P3H1, you also have a phenocopy of a loss of CRTAP because of this mutual stabilizing effect. And so Erica Holman in the lab, who's a graduate student, designed an experiment where she looked for, using an evolutionary trace approach, conserved residues which would be important, and predicted to abolish the catalytic activity of the enzymatically active component, P3H1 of the complex, without destroying its structure. And she studied these in terms of transient transfections, and just by looking at the merge basically of the P3H1 mutant as well as CR-TAP, that in fact some of these point mutations should act as she had hypothesized in rescuing the trimeric protein complex. So she generated these mutants and eventually made knock-in mice. Now, she also generated stable cell lines to study this more clearly, and you can see a wild-type situation where you see P3H1, CR-TAP being expressed. You can see in a P3H1 null cell, you lose both components of the complex. If you express wild-type P3H1, you rescue P3H1 and CR-TAP. If you express the mutant, again, you rescue both CR-TAP and P3H1, and that's just an empty control. More importantly, when she looked at on a protein level, she does in fact get this rescue. So the key lane to look at in this situation is lane 2, which is putting the 662 mutant in this case, which is predicted to be catalytically inactive, but structurally intact, and in fact rescues the CR-TAP in the Western analysis. And so she went about and generated mice using this construct. So this is a knock-in mutation at the 662. So again, catalytically inactive, structurally intact. And what she found immediately was the mice had normal growth. This is in distinct contrast to the P3H1 loss of function or the CR-TAP loss of function. And importantly, there was no dramatic difference in the length of the bones, which was what we see. But interestingly, there was a bone phenotype, though. There was low bone mass in these mice when you look at wild-type versus mutant, and this is the micro-CT analysis. And so when she went about systematically looking at many, many of the tissues, and I don't have time to go through all of the data, but what she did here was compiled the reported, as well as our reported phenotypes of the CRTAP knockout, cyclin-filin B knockout, the P3H1 knockout and her knock-in mice. And what you can immediately see is that there are certain features that are common. So for example, in all situations, you lose the pro-986 hydroxylation event. But there's also distinct features. So for example, the growth phenotype I already highlighted. These mice don't have a significant growth phenotype, suggesting that the cartilage component of the phenotype is preserved in these versus not in these mice. While if you look, the growth curve is normal, the appearance is normal, but you get low bone mass. So for example, seen here, all throughout. Very similar to what you see with the hydroxylation status. You get a divergent effect on collagen diameter. You get a divergent effect on cortical bone as well as cortical bone mechanics. You get the same effect in terms of lung alveolar spacing, but not on skin. And so what this is really beginning to tell us is that some of the features we think is due to, in fact, the loss of CRTAP. And part of this is because P3H1 is part of a family of 3 enzymatically active components, P3H2 and P3H3. And there seems to be redundancy. And we've seen some of this now by looking at some of the other mutants in this family. So one explanation is, in fact, redundant function of the enzymatic component. The other may be, in fact, that these enzymatic components target different hydroxylation sites. And that's, I don't have time to show you some of the data, but that's also beginning to correlate with some of the phenotypic feature. The take-home lesson, though, is, in fact, there is a distinct difference between the catalytic and the structural function of this complex in thinking about the OI phenotype. Now, what is the consequence, then, in addition to the effect on fibril diameter? Well, one of the things that we've begun to look at is alteration in, fact, the cell-to-matrix signaling. I don't have time to show you a lot of the data we've generated on TGF-beta, so I'll just highlight some of the data we've generated on Wnt signaling. Not surprisingly, when you alter the matrix, much like the lesson that Hal Dietz has taught us from Marfan syndrome, you're going to alter cell signaling. In this case, this is the bone of CRTAP mutant mice. You can see an alteration in phosphobeta-catenin, and this leads to, in fact, an increase in the phosphobeta-catenin that's present, supporting that, in fact, there's a decrease in Wnt signaling that's present in the mice. And so not surprisingly, we then treated these mice, and this is in collaboration with Amgen, using their anti-sclerostin antibody to increase Wnt signaling. You can see a dramatic effect on both on long bones, but also in spine bones. And this is a quantification of many of the micro-CT parameters. In this case, the white bars represent the treated mice, the gray bars represent the CRTAP placebo-treated mice, and wild type is in black. And you can see restoration of many of the parameters on micro-CT analysis using the anti-sclerostin antibodies, suggesting that here we are not only increasing bone mass because of the effect of what anti-sclerostin would do, but we may be actually also treating an underlying signaling defect. And this translates to an alteration in biomechanics. So if you look at the extrinsic properties of treated mice bones, you get improvement. But as you would expect, this would not treat necessarily the intrinsic property that would be determined by the abnormal in fiber assembly. So if you look at toughness to failure, elastic toughness, and other biomechanical measures, the treatment does not, in fact, improve the intrinsic property. So again, consistent with the sort of multifactorial component of this disease. So a picture that's emerging is that while this is a simple Mendelian disorder, the pathophysiology is complex, affecting multiple levels, both in terms of extracellular fiber assembly as well as cell signaling. Now, just taking a step back, what we now have seen is a proliferation of other genes. So for example, FKBP10 and HSP47 is a complex that was identified in that original paper as a collagen binding complex, and these now have also been shown to be mutated, and these clearly affect other aspects, not necessarily just fiber assembly. Here, UPR stress as well as autophagy may actually be a very important component of this phenotype. One of the emerging, and I'll finish my talk on this, is some of the exciting work that's coming up on some of the genetics of different types of OI. Because beyond just collagen fiber and collagen cell matrix interactions, some of the newer phenotypes of OI are actually pointing to other mechanisms of bone homeostasis and development that we've not appreciated. Something that we've begun to work on in the lab is OI type 6, which is an osteomalacia type phenotype, as you can see here, with the increase in osteoid staining. Erica had shown that mutations in this gene, SERPINF1, causes OI type 6, and they're human beings who walk around with basically no SERPINF1 in their blood. Well, what is SERPINF1? It's actually pigment epithelial-derived factor. This is a neurotrophic factor, a cell differentiation factor, one of the most potent anti-angiogenic factors known to man, and antagonizes VEGF. So completely shocking that a protein well studied in this vascular arena actually causes a bone phenotype in humans. And she, in fact, looked at the mice, which have been described several years ago, but no one focused on the bones. And as you can see, there is a bone phenotype, a low bone mass phenotype. And Kyun-Sang Jung, who's actually a postdoc who was in Fanxin's lab as a grad student, has done some very interesting studies looking at knockdown as well as overexpression, has shown that he can recapitulate the mineralization phenotype in vitro. And clearly, PEDF has a very central role in controlling cell mineralization. So when he knocks down PEDF, you can see loss of mineralization in this MC53 cells. When he overexpresses human PEDF with a virus, a lentivirus, you can see the acceleration in mineralization with associated changes in some of the marker genes. Now, this can be recapitulated with primary cells. If you take bone marrow stroma cells from the PEDF knockout, you can in fact see the decrease in mineralization. If you take transgenic mice where we overexpress PEDF from osteoblasts, you can see the accelerated mineralization. This suggests perhaps that there could be a treatment. This is a secreted protein, well studied in the vascular world as well as treatment for eye diseases. Could we in fact give PEDF as a therapeutic approach in patients with OI type 6? Well, it turns out it's not as simple as that. Taka Mazatake, who in the lab, who's in the gene therapy part of the group, did a very interesting gene therapy experiment where he expressed PEDF using a helper-dependent adenovirus, long-term sustained expression after a single injection. And initially, he saw a rescue of the growth phenotype in these mice. So the red represents the wild type. The black bar represents actually a virus expressing PEDF. The diamonds represent an empty vector. So you rescue the growth phenotype. What's interesting is we do not rescue the bone phenotype. So these data suggest that expressing PEDF in the liver, much like you would do, let's say, protein therapy, is not sufficient to rescue PEDF, at least in the context of this expression experiment, which is an overexpression. So the amount in the blood is actually quite high, 10 to 100-fold above normal. So then Erica asked a question, do you need expression within osteoblasts? Could this be a paracrine effect? And so she actually generated transgenic mice, and let me end with this, and surprisingly, again, we did not get correction. Not only that, we actually get a worsening of the bone phenotype when you generate transgenic mice overexpressing PEDF. So even though in vitro we have the exact effect that we would predict based on the human phenotype in terms of mineralization, when you do gain versus loss of function, we don't get the same effect when we overexpress it either in bone versus in liver, suggesting that perhaps maybe either the effect is cell autonomous or perhaps we may need to actually fine-tune the level of protein, much like you would get in a morphogen like TGF-beta. And so let me end by saying that there's an enormous amount of exciting work going on where this rare disease, and there's more coming on the horizon, has really pointed to novel mechanisms as well as insights in existing ones in terms of matrix and bone. The 3-hydroxylation complex pointing to cell matrix interactions, this FKBP10-HSP47 interaction on chaperone of collagen, as well as perhaps collagen-dependent and independent effects. PEDF is a nice example of one where we're affecting primarily, we think, mineralization and a mechanism of mineralization. A new paper has come out looking at BMP1 and how loss of function of BMP1 can also give you a brittle bone-like phenotype. And this could involve collagen. It may not, because BMP1 obviously can target collagen as a protease. There are many more coming down the pipeline, which I think will really revolutionize what's going on in the field. Let me acknowledge the lab. I've tried to acknowledge some of the individuals who've contributed to the work, as well as collaborators along the way. I wanted to also take 30 seconds to acknowledge Dave Ramoyne. Many of you know that David is really a father of the field of clinical skeletal dysplasia, and he passed away two weeks ago quite suddenly after fighting an acute disease. And he's really been a mentor and a colleague for many years, and without much of the work that he's done over his career, I think the skeletal dysplasia field would not be what it is today. Thank you.
wonderful summary, Brendan. This last osteomalacic disorder, can you speculate as to why there's an abnormality of mineralization, one that you can actually mimic in vitro? Wonder what your thoughts are about that.
Right. So there are two possibilities. I think that what we think, the one that we favor, or that I favor at this point, is that PEDF is produced by the osteoblast. That's clear. So I haven't had time to show that. It's pumped out by the osteoblast. What we think is happening is it's probably working on a receptor not yet identified on the osteocyte. And so what we're seeing with the in vitro effect probably is the effect that we're seeing in osteoblast differentiation, which is real but distinct from the mineralization phenotype, which is what predominates in the human situation. And so we're not able to study the osteocyte effect. So I guess one way to think about it is PDF is working in a paracrine fashion, but between the osteoblast and the osteocyte. That's sort of the model that we're looking at right now. Now, the question is, what's the downstream target and signaling effect? And so we have some data to suggest that ERK signaling is actually affected in PDF mice. What we don't have is a receptor. And so we're trying to find the receptor, and we're predicting that the receptor that mediates this effect will be sitting in osteocytes. The corollary, or the prediction from that, would be that mutations in that receptor may also give you an OI, or brittle bone phenocopy, and we're actively looking for that.
So why would any of those things affect mineralization? Is alkaline phosphatase affected, pyrophosphate,
right.
any of the?
So we've looked at all of that in the mice. There's no change in pyrophosphate, but we do see alteration in some of the regulators of mineralization. So for example, ENPP1. So we think that's the ultimate downstream effect in terms of the PDF phenotype.
In that in vitro assay that shows abnormalities, can you mix together normal and abnormal cells and see trans effects or not?
So we haven't done that yet, but that's something that's in progress.
Very last talk, I have one question. Do you think the serotype complex selectively target the spatial amino acid in the collagen fiber, or you can interact with other amino acid site in the fiber?
So the question was, just so I'm clear, is whether the trimer or the complex in the 3-prolyl hydroxylation complex interacts with a specific site.
Yeah, or
with multiple ones, right? So we think it actually interacts with a specific site. It lands on this carboxy terminal part of the trimeric complex, initiates hydroxylation event, and we think that's what sets the register for then the subsequent hydroxylation. So we do think it loads on with other complexes. So there's a whole group of complexes that load on right at the carboxy terminal where collagen assembly occurs, and this is one of the complexes. We think that FKBP10 and HSP47 also loads on at that point. So there is a loading point.
Thank you.
Thank you, Brendan, for a wonderful talk. So having touched upon the genetic basis of a very commonly studied skeletal disease, now we're going to switch gears to the other equally important aspect of mechanism that causes human skeletal disease, that is the epigenetic control of genes. So with that, we're going to welcome Dr. Stein to the podium to tell us about this control as an important mechanism for both normal development and also for pathology of the skeleton. So I understand that he's going to give a broad overview of epigenetics for this audience, and then he's going to provide some more concrete examples from his own laboratory. And I understand Dr. Gary Stein has just recently moved. That's news to me too.
Well, first I want to begin by expressing appreciation for the opportunity to attend and participate in the meeting. It's obviously it's highly informative, and it's a beautiful place in the world. So thank you very much. What I want to do is to focus on several dimensions to epigenetic control that are very much linked to a biological regulation in general, and specifically to skeletogenesis and pathologies that are associated with bone, But at the onset, let me emphasize that the work I'll be talking about represents, well, let's see, we'll try another pointer. This one works. Represents a long-standing collaboration with Janet, Andre, Martine, and Kaleem. And these are people in the lab who have been critical in terms of not just carrying out experiments, but also in terms of designing the experimental strategies. So what we've been trying to do over the past 10 years or so is to try to understand how you both organize and retain regulatory machinery for both genetic and epigenetic control. And the concept of retention, of course, is very key because DNA is transmitted to progeny cells during mitotic division, as is a number of other growing examples of regulatory information that are epigenetically transmitted. So what we are beginning to appreciate, and I think it's coming from various contexts, is that both the progression of skeletal disease is related to both a DNA-encoded information, we've heard several examples of that, and epigenetic control is equally important. So what do we mean by epigenetic control? And the classical dimensions to epigenetic control relate to DNA methylation, that it relates to histone modifications, and there are increasing examples of RNA-mediated gene silencing. What has become apparent to us over the past couple of years is that there is a very defined organization of machinery within the interphase nucleus of the cell, and that in turn is a parameter of epigenetic control, but equally important, the regulatory machinery in part remains associated with target gene loci during mitotic division, reflecting yet another dimension to control. So the common denominator is that regulatory machinery, be it regulatory machinery for replication, for transcription, for apoptosis, for repair, for splicing, the common feature is that all of it is compartmentalized within the nucleus. It's architecturally organized and occupies a series of microenvironments. And what you're looking at here are just immunofluorescence images of the proteins that are associated with these key biological processes. And these are not overexpression experiments, which means there's a significant amount of this regulatory machinery present in the living cell. But all of this is present So that means you should be able to superimpose these images on top of one another, and that's the complexity of architecturally organized regulatory machinery within the nucleus of a cell at any given point in time and continuously. But these are not static complexes. These are not static cellular compartments, but these are very dynamic because if you take one example, and that's the regulatory machinery for histone gene expression. These are genes that are expressed in conjunction with DNA replication. They are activated at the onset of S phase, and they are silenced at the end of the S phase of the cell cycle. And you can see the complex is going to organize right at the G1S phase transition, and it's going to disassemble at the completion of S phase. So these are the diverse types of microenvironments that are present, and this is the kind of dynamic and functionally linked nature of these types of environments that one sees. So what I want to do is to focus on mechanisms associated with forming these types of microenvironments. And the example I'm going to use is the RUNX AML transcription factor, which I think everybody is aware is involved in osteogenesis and chondrogenesis, the central theme of this meeting. But the other member of the AML family is involved in hematopoiesis and in myeloid differentiation. So how do we link epigenetic control with compartmentalization within the cell nucleus? Well, if we take the bone-specific osteocalcin gene and look at the promoter, what you see here is a cluttered underrepresentation of the kinds of regulatory complexes that are formed. And the key element of this type of organization, and there are certain common themes to it, is here you can see the AML-RUNX transcription factor binds to 3 sites. It's a scaffolding protein, so it strategically locates a series of regulatory cohorts at particular sites, and it's a dynamic process. It changes with respect to the physiological requirements of the cell and either the activation or suppression of that gene. But amongst the factors that it's going to scaffold are components for epigenetic control. histone modifying factors, DNA modifying factors. So along the promoter of a gene like a bone-specific osteocalcin gene, but genes in general, one begins to see a very clear organization of regulatory machinery. Then when one looks at the interphase nucleus, you see about 150 to 300 of these foci of the Runx AML transcription factor, illustrating yet another level of compartmentalization. And these are clear microenvironments. And again, this is not an overexpression experiment. This is the in vivo representation. So how can one begin to understand mechanistically the organization of a bone-specific regulatory protein at a series of defined sites within a nucleus? And with that information, can one utilize that as a way of targeting skeletal disorders? Well, the approach to mechanistically understanding how this factor localizes within a nucleus is quite straightforward. Since we know if you look at the AML transcription factor, the DNA binding domain and nuclear import signal are located in the N-terminus, all we did is constructed a series of C-terminal deletions, subsequently point mutations, and identified this orange region in the C-terminus, which is sufficient for dictating subnuclear localization. Because you could take the 31 amino acid C-terminal subnuclear targeting signal, ligate it to Gal4, and you can see the punctate organization, which is similar to what you see for the wild-type protein. Here's the wild-type protein, and it completely co-localizes. But probably more important is that there's a very significant change in the ability for a target gene to transcribe. So the obvious question becomes, is this type of organization present in the nucleus of a living cell? And if you look at a green fluorescent protein tagged AML Runx transcription factor, here you can see the punctate domain present, the punctate domains present, 150 to 300 sites. Here you can see the same one present over a 30-minute period. And if you introduce a point mutation in that C-terminal sequence, the protein is still there, but now you can see it's spread all over the nucleus and in the cytoplasm as well. So the obvious question becomes, is there specificity to this type of a subnuclear trafficking signal on the AML transcription factor? And the answer is yes, because there's unique sequence specificity. The crystal structure shows a unique conformation, and based on the crystal structure, we can now introduce a single point mutation in either end of this loop, and the consequence is loss of subnuclear targeting and even a more dramatic effect on capability to transcribe. So this begins to go ahead and contribute to a picture of multiple pieces of architectural localization information within a transcription factor. A nuclear localization signal that gets you into the nucleus, a subnuclear trafficking signal that gets you to a site within a nucleus, and then you could utilize your DNA binding domain to support promoter recognition. So is this type of a mechanism operative in a living cell during a developmental process? And is it operative in a living cell as well as within a living animal? So the experiment that we turned to was based on the knockout, and this is actually work of Komori. If you do a knockout of the AML transcription factor, you get normal cartilaginous developed with minimal bone formation. We did a knock-in. We substituted the bone AML transcription factor for one that lacks the C-terminal subnuclear trafficking signal, and the phenotype is almost identical to what you see for the knockout. So that would suggest that entering the nucleus is not sufficient for a bone-specific transcription factor to be operative, but there's a stringent requirement for correct location within the nucleus, and that is dictated by a C-terminal domain on the transcription factor. So we then looked at the myeloid AML transcription factor, which has a similar organization with an almost identical subnuclear trafficking signal, and a single point mutation in that subnuclear trafficking signal blocks the transition from a blast cell to a very differentiated myeloid cell, and you end up with the persistence of a blast-like cell. So if this type of information is critical for function of this transcription factor, what happens during mitotic division? And that's a key question, because during mitotic division, you completely disassemble the nucleus. The regulatory machinery is going to go ahead and to be reorganized, yet the progeny cell emerged from mitosis with the requirement to be able to transcribe with fidelity. So the experiment we did was simply to follow the cells right through the cell cycle, hour by hour. And now when we looked at the focal organization of Runx AML, be it the hematopoietic AML or the bone AML, instead of 150 to 300 of these foci, the G2 cell right before mitosis has 300. The progeny cells following mitotic division each have 150. And that's consistent with retention of these transcription factors in a focal organized type of a context right through cell division. So we actually looked at the dividing cell, and here you see your G2 cell, your 300 foci. Here's your dividing cell. There's your 300 foci, either on the chromosomes or associated with the microtubules. If you look at a cell right through mitotic division, and this is really the crux of trying to understand epigenetic control, you could see the Runx foci on the chromosomes in prophase, metaphase, anaphase, and telophase. Is the association specific? Well, it's sequence specific because if you put a point mutation into your DNA binding domain, you lose the interaction of the bone-specific transcription factor. But what is probably even more convincing is if you construct a metaphase chromosome spread of a dividing cell, here you can see the chromosomes, here's the chromatids, and symmetrically located right on the sister chromatids, you could see your Runx AML foci. In this case, we're looking at the bone-specific Runx transcription factor. And I should emphasize again, this is not an overexpression experiment. This is looking at the endogenous transcription factor. So to be able to formally establish that what we're looking at is sequence-specific interaction, the experiment we did was to ask in a global gene expression profiling study, what is expressed before mitosis, that's expressed after mitosis, that will not be expressed if you do a Runx knockdown. And when we did that, we were able to identify 40 target genes, all of which had Runx sequences in their promoters. We then did chromatin immunoprecipitation analysis of metaphase cells and verified that indeed 38 of the 40 had the Runx transcription factor remaining associated with the target genes throughout mitotic division. But what surprised us, and this was not a clever prediction, but rather, was an observation, was that in addition to the Runx transcription factor controlling the Pol2-driven tissue-specific genes, we also found that it was controlling ribosomal genes. And when we looked at the metaphase chromosome spreads more closely, you could see Runx co-localizing with UBF on each of the acrocentric chromosomes, and again, symmetrically located on the sister chromatids. When you look at the cell following mitosis in interphase, there you could see that the Runx transcription factor co-localizes with UBF at the region of the nucleolus where the ribosomal genes are transcriptionally active, and that was confirmed by immunogold labeling. So that suggested that for the first time, a tissue-specific transcription factor is controlling the phenotypic genes as well as ribosomal genes, and that provides a potential link between control of growth and control of phenotype. So the obvious thing to do was to look at the ribosomal gene promoter, and there we found 40 AML sites on every ribosomal gene promoter. By chromatin immunoprecipitation analysis, we showed that we could chip and rechip the Runx and UBF, so that shows real occupancy of an active complex. You could do knockdown experiments and overexpression experiments with AML Runx and show a responsive change in the rate of ribosomal gene expression. But probably more important was that you get a very striking change in capability to support protein synthesis. So again, what this began to suggest to us, at least for the bone-specific AML Runx transcription factors, is that you have a potential link between cell fate, cell cycle control, and cell growth control. So is this restricted to the bone-specific AML transcription factor? And the answer turns out to be no. We find a similar observation for Runx1, Runx2, and Runx3. And then when you turn to cancer, you turn to myeloid leukemia, the A21 translocation fusion protein also epigenetically controls the phenotypic genes and the ribosomal genes. And what's beginning to emerge now is that while the phenotypic transcription, RUNC's phenotypic transcription factors are carried through mitotic division, a subset, but not the entire cohort, of co-regulatory proteins are going to be carried along to the progeny cells. So epigenetic control by a tissue-specific transcription factor is partially operative and not completely active. Now, if you look at osteoblast differentiation, myoblast differentiation, adipocyte differentiation, the same story seems to hold. What you're doing with RUNCs, what you're doing with MyoD, and with CEBP is co-regulating the phenotypic transcription factors and the ribosomal genes. So in summary, what this suggested to us was that when we look at epigenetic control, one is to consider DNA methylation and histone modifications, but equally important, bookmarking of target genes by transcription factor occupancy of these target genes during mitotic division. So what I want to end with is an example of how this also relates to cancer that is associated with bone, and specifically the metastasis of breast and prostate tumors to bone. This is really based on observations that have been made over a number of years, not from our research group, but from a number of groups, that metastatic breast and prostate cancer cells, those that are going to end up residing in bone, express a number of the bone phenotypic proteins: osteopontin, osteocalcin, osteonectin, and other bone-specific transcription or bone-related transcription factors as well. So the first question we asked was, are you regulating these bone transcription factors in a tumor cell by the same phenotypic transcription factors that regulate them in a bone cell? And the answer turns out to be yes. So what we wanted to ask was, can you actually show that in vivo in terms of an effect on tumor growth? And what you can see here is this is a metastatic breast cancer cell, an MDA231 cell, significant tumor in the mouse, and when you knock down RUNCs, you can see a very striking inhibition in tumor growth. And overexpression is going to go ahead and exacerbate tumor growth. So what we wanted to ask is if one can utilize the mechanism for subnuclear trafficking as a way of trying to block the progression of a metastatic breast cancer cell in bone. So what we did was an intratibial injection of the MDA231 cell. And here you could see in 20 out of 20 animals, after 19 days, almost complete tibial erosion. In 16 out of 20 animals that carry the AML transcription factor with a single point mutation in the subnuclear trafficking signal, you could see that most of the tibia is going to be retained. And in 20 out of 20 animals, if you remove the entire C-terminus, you could see that you have retention of the tibia. So what I've tried to show you is that there are a number of levels of nuclear organization that one sees within the nucleus of a cell for regulatory machinery, certainly for transcription, but also for replication, repair, control of apoptosis, and transcript processing. And we're beginning to understand mechanistically how each of these different levels of nuclear organization is operative and contributes to gene expression. But each of them are functionally linked to the manner in which gene expression is controlled, and each of these provides insight into a potential either diagnostic target or therapeutic target. And in part, some of these are proofs of principles, but in some cases, epigenetic mechanisms are becoming a standard of care for cancer treatment. So I'm going to stop here, and I welcome the opportunity to answer questions people have. Thank you very much.
Hi, Gary. Nice talk. So you nicely showed that the subnuclear trafficking signal is necessary for the localization in the nucleus. But you showed that you have the mutation, so that it still goes to the nucleus. But does it actually bind? Have you done CHIP to show that it still binds to DNA? Or is that a factor that's sort of like required by having modifying enzymes at the promoter region that actually recruit that factor?
So if one goes ahead and if you block the capability for punctate organization, you get a very, very significant decrease in DNA binding. And that isn't terribly surprising, because now what you've done, genes are also punctately localized within the interphase nucleus into chromosomal territories. And if the factor is going to be uniformly distributed throughout the nucleus, rather than being focally organized, we have a significant quantity, you're decreasing the ability to go to drive a binding reaction. So you get a limited amount of interaction, and the interaction takes place over a more extended period of time.
I have an addendum on that question. So is it possible that these sites of internuclear concentration for the Runx factors are essentially dating bars for transcription factors to meet their co-activators? And one could examine this possibility by doing, instead of chromatin IP, doing co-IP, and asking, is the association with Runx with any of the slew of co-activators that you've been studying, is that compromised in the absence of correct nuclear localization?
I'm not 100% sure that I fully understand the question.
So does the transcription factor have to get to the right place in the nucleus to bind to histone modifying enzymes, to SWI/SNF components, to stuff that transcription factors like to bind to?
So in other words, can you go ahead and IP complexes that have a particular subset of the co-regulatory proteins that you would find, on the promoter? And the answer is yes. You find differences between what you can show by plain IP and what you show at CHIP, or what you could show by CHIP, and that might suggest that the foci that form, well, first of all, you're looking at it with one antibody if you're doing a CHIP, or if you're going and you're doing an immunofluorescence experiment. So it would suggest that certain complexes could form independent of localization, and others are going to go ahead and require, going ahead and localizing. But it's combinatorial, and that's sort of consistent. That's consistent with the formation of these kinds of complexes. The thing which becomes confounding in terms of a clear interpretation is that if you do a screen for protein-protein interactions, you could end up with a whole series of candidates. You take them and now you try to confirm them biochemically, and you can. You try to confirm them by immunofluorescence, and you can. But you'll find differences in the particular co-regulatory complexes at the different foci, so they're not all the same. When you do an IP experiment, you're going ahead and you're combining all of that. And that in turn seems to be related to the particular foci and the particular genes that are located at the different foci, because these foci represent different regulatory complexes. And some are active and some are inactive. And that you can show very directly by just coming in with an antibody to the hyperphosphorylated or the hypophosphorylated form of RNA polymerase II. And some of them are transcriptionally active and some of them are not. And you could also do that just looking directly at the level of transcription in them.
Thank you.
I love the experiment in which you could drag GAL4 to these regions with that specific protein sequence at the C-terminus, which is apparently sufficient to do so. Do you know what that sequence at the C-terminus of RUNX2 is binding to get into the complex? And a second question, can GAL4 have transcriptional activity when it's been dragged into that RUNX2 complex, or the complex that RUNX2 usually goes to?
Okay, so when the problem to us seemed quite straightforward. We went ahead and did a series of deletions and point mutations and identified a 31 amino acid sequence that was responsible for it. So we then went ahead and started doing fishing experiments to try to understand what it interacts with. And what we did was we pulled out a very extensive series of proteins, all of which we were able to go in to verify interacted. But you formed different complexes depending upon the particular foci that you were looking at. That came from the immunofluorescence experiment. So, in other words, initially we were looking for a docking protein, and then we were going to go ahead and systematically reconstruct the complexes. And that wasn't quite straightforward because you have multiple proteins that interact with that sequence. When you look at the sequence, you're looking at protein, and then you're looking at scaffolding interactions. So they are heterogeneous. So it's a large number of proteins, all of which are involved in RUNX regulation, different subsets regulating different RUNX target genes, and differences in the complexes regulating the target genes if the gene is active or inactive. So there isn't any one type of a code to that sequence that's going to tell you the entire cohort of proteins that are binding there.
Too bad. What happens when to the activity of the GAL4 when you make it go to those punctate places? Can it still act as a transcription factor?
I'm sorry?
The GAL4. I wondered whether when you drag it into those RUNX2 binding areas, whether it can still act as a transcription factor.
Haven't looked at it that way. It's a good question. To be totally honest, the reason that we haven't, the problem is that when we start doing overexpression experiments, you can only work at very, very low levels of overexpression and get a transcriptional response that's going to go ahead and to be meaningful. Knockdown experiments are much easier to do. So, and in fact, you begin to start seeing accumulation first at appropriate sites, and then you start seeing it at non-specific sites. So it's an important question, but it's a difficult one to address. Yes?
So Gary, great talk. I have a question about the amount of RUNX2 that's in a cell. So you have an osteoblast, you see 300 punctate loci. Maybe each loci has 2 or 3 RUNX binding sites. So are you suggesting, or is the implication that there's going to be about 600, 1,000 RUNX2 molecules? And then, when that cell is divided, you're having half as many punctate loci in the daughter cell, but you eventually need to have RUNX2 sites at all the sites that the original interphase cell had. So when are new RUNX proteins being made, and how are they finding their way back to the gene loci that they need to regulate? What insights can you tell us about that?
Okay, well, starting with the first question. There are large and there are small RUNX sites, okay, and the larger ones, okay, there are larger and smaller sites, and that appears to relate to the particular genes that are located in those regions and a number of RUNX sites that are present on each of those target genes. Your ribosomal genes have 40 to 45 RUNX sites with significant occupancy. A gene like osteocalcin has 3 sites, in a proximal region, a number which go, which are going to be upstream and downstream from it. So it depends very much upon the particular genes that are present. Following mitotic division, you have half of the foci that are present, and they seem to go ahead and to reform in a reasonably progressive at a reasonably progressive rate during G1, S, and G2, with perhaps a blip that occurs during S phase, which is when you're going to get when you're going to go ahead to get a duplication. It seems unlikely that the protein is entering the nucleus and going to a defined site. More likely, what you're doing is differentiating the nucleus and forming a certain critical level, and then another site forms. And that seems to be the complex that's interacting with genes, because that's just based on the amount that you find when you're doing chip analysis.
I try to make it short. So it's a chicken and egg thing. When the cells start to differentiate, is RUNX2 recruited to specific nuclear subdomains and then activates genes that are, or binding sites that are in the neighborhood, or does it bind to its target genes and that creates a subdomain in the nucleus?
It's a very good question. I really can't give you, a definitive answer, but clearly you utilize newly synthesized as well as some of the pre-existing RUNX at the time of differentiation. But there are some genes that RUNX dissociates with during differentiation too.
So we'll break for 10 minutes. Come back, please, at Beijing time, 11:05.